Today I'm going to talk about radiographic technique, primarily coming from Bushong Chapter 15. And this next test covers Chapter 15, Chapter 16. Chapter 16, well, first off, Chapter 15 is called image acquisition. It's really radiographic technique. Chapter 16 is patient image optimization, and that's really patient factors, including things like body habitus, thickness, density, and pathologies and things like that. So in this, what I'm going to talk about are the exposure factors, and there are 4 prime exposure factors. That will be kVp, which I've done in detail in videos. I'll link to this. Image system characteristics, and we'll talk about that. Patient factors, image quality factors. I'll talk a little bit about technique charts, AECs, and how they work. And I'm going to touch on these two down here, tomography and macro radiography, but we're not going to talk too much about those because the technology for both of those are, I won't say obsolete, but they don't have as much impact in diagnostic radiology as what they once did. So the 4 prime exposure factors are kVp, MA, exposure time, and distance, and each one of those require manipulation for all exams. All are under control by the technologist, and everything else is a secondary factor. So there are some other things that can affect the amount of radiation that strikes the image receptor, the quantity and quality both of what hits the image receptor can be controlled in part by some other things, but these are the 4 big ones. So I did kVp in detail, so we're just going to pass through kVp and we're going to get to MA and time. And MA we're going to call intensity. Intensity in this case is what controls directly the quantity of x-rays that we create. So MA stands for milliamperage. You should know that by now. Amperage is just a measure of electrons. So it's a numeric count of electrons, and it's the same type of amperage as what you have in your house and your car. Any kind of electric appliance uses amperage. It's just flow of electrons is all it is. We'll refer to it as intensity. We'll refer to it as quantity. And it whenever we adjust our MA, if you go back to the kVp videos, you'll see a diagram of circuits that were used in at least a couple of the videos, or at least one of the videos, maybe 2 of the videos. And the MA circuit is a circuit that's down on the bottom, and it has a number of different elements to it. It's got an MA selector, which is kind of, sort of, like the auto transformer in that you can increase or decrease the intensity through that. It comes out of that and it goes into a step down transformer to reduce the voltage before it goes into the x-ray tube. The amperage is totally unrectified before it gets to the x-ray tube. It's unrectified, it doesn't need to be rectified, and we want low voltage, so it's going to go through a step down transformer so that our voltage is going to be between 15 and 25 volts, so that the electrons don't travel across the tube before we're ready for them to. So when we adjust our MA, what we're doing is we're adjusting how many electrons we can stack on a filament. So we've got a couple of things there. One is that the number of electrons we put on a filament directly correlates to how hot that filament's going to get. So when we hit the prep button, what we're doing is we turn on the rotor so that we spin it around and around, and at the same time we start to congest those electrons on that filament. So what that's going to do is, if we get enough of them on there and it gets hot enough, some of those electrons are going to, since they're all negative charges, are going to repel each other, and some of them are going to try to push away from that filament. And that's what we call thermionic emissions. We're boiling off electrons so that they create a space charge, and that space charge is what we call thermionic emissions, and it's just a collection of electrons on and around the outside of that filament. So the MA directly, the higher the MA, the more filament current we have, the more thermionic emissions we have, the larger the space charge. So the MA directly controls the current at the filament. Amperage, even though we use MA being milliamps, that's 1/1000th of an amp, what we get are a tremendous number of electrons. So it's 6.3 times 10 to the 18th power That's if you took off from this point right here and went that way 18 times, that's how many electrons you would have in 1 amp. But we don't use amperage, we use milliamperage. So if we did use an amp, 1000 MA would be 1 amp, and that's how many electrons we would have in a 1 mass or 1000 mass exposure. So even though we use milliamperage, what we're doing is we're cutting down the amperage just a little bit, and it's pretty, I won't say it's insignificant. We do lower the number of electrons that we create or we use, and therefore pardon me just a second, this is making me a little bit crazy. Okay, so we don't use a full amp, but it's still a tremendous number of electrons. So what we learned from physics last semester is that in creation of amperage or creation of X-rays, X-ray is very inefficient. So even if only 1% of the electrons we send across the tube become X-rays, then that's still 1 to the 15th power X-rays. And if only 1% of those transmit through the patient, or less, yeah, we'll say 1%. And that's still 1 to the 13th power number of electron or X-rays coming through the patient to strike the image receptor. So it's a tremendous number of electrons that we're going to create or send through the filament to send across the X-ray tube to create X-rays. So the higher the MA, the higher the thermionic emissions, the larger the space charge, and the more electrons we're going to send. And with the more electrons we send, the more X-rays we create. The number of electrons that we send across the tube and interact on the target directly impacts the number of X-rays that we create. Since it's a direct relationship, we increase our mass by a factor of 2, then MA and time together to create mass is what we want to use to create our intensity and control the quantity of X-rays that we create. So the effects of MA on potential energy, it doesn't have any. On kinetic energy, it doesn't have any. On beam energy, it doesn't have any. On penetration, it doesn't have any, except for whenever you increase your mass. If you doubled your mass, you double the number of photons that you penetrate, but you also double the number that are absorbed inside of the patient, double the number that are scattered inside of the patient. So the percentage doesn't change, so don't let that trip you up. The penetration, it doesn't control or really even affect the rate at which we penetrate. So it doesn't affect frequency and wavelength. 100% of what controls the frequency and wavelength of a given X-ray photon is kVp. So kVp controls those two. So really the only thing that MA changes is the heating of that filament, creation of the space charge, the number of electrons we send across the X-ray tube, and the number of X-rays that we create once they impact that target. So exposure time and its role in mass, short exposure times are preferred so that you don't introduce motion artifacts. So we have two different types of motion. One will be voluntary motion, one will be involuntary motion. Involuntary motion is anything the patient cannot control. So breathing is reflex, so you don't really have to think about breathing all that much, and you do it anyway. And even though it's a reflex and you do it anyway, we're still going to call it voluntary motion because most patients can hold their breath. Where you have involuntary motion are things like heartbeat, movement of the bowels. If your patient has some sort of pathology that they can't be still, or if they're a pediatric patient, you could argue that in those cases what you've got is involuntary motion, even in breathing. But if the patient is an adult-ish age patient and they can perform what you ask them to perform, then all of that would be voluntary, and the involuntary would be the things like the heart rate and the bowel movement. So if time gets too short, there is a little bit of a component of quantum model in our exposure time, or at least traditionally there was. Quantum model, I mentioned it in multiple videos, is something that we have not been able to demonstrate on our machine in our lab for the last couple of years. My students have tried over and over again, could not get the quantum model to display. So quantum model is kind of a noisy image, and it occurs because there's not enough radiation exposure to the image receptor. So Bushong he mentions in the textbook, quantum models kind of like watching rain on a sidewalk, where you've got the rain, whenever the rain very first starts and you just get splotches and you can differentiate between dry ground and the wet ground. He kind of compares that to quantum model. And I recorded a couple of videos at the beginning of a rain shower, I think it was last year, and it's somewhere in one of my playlists. I'll see if I can find it and post it here in the description so that you can see, kind of get a better feel for what that is. So quantum model is just a modelly appearance. It's a noisy appearance. It's kind of like static in a radio signal. It's where you don't get enough signal to the image receptor, and it results in a modelly appearance or a speckly appearance on your image, and that is quantum model. So quantity, quantum, model, speckly looking appearance. Quantum model is a speckly looking appearance because not enough signals get into the image receptor. So where we have mass, we've got MAN time. So MAN time combined together, and when kVp is applied, we get tube current. We don't get tube current until kVp is applied. All we have until that point is filament current. But once we apply the kVp and the electrons jump across the tube, we have mass at that point. So mass is half of the equation, Ma is the other half of the equation. Together they create mass. So law of reciprocity. What we have with law of reciprocity is, let me do this real quick. Reciprocity definition. Well, don't want to open it. It says the practice of exchanging things with others for mutual benefit, especially privileges granted by one country or another organization. There we go. So what you see is behavior in which two people or groups of people give each other help and advantages. So reciprocity just means give and take. So if you enter into some sort of agreement with somebody and you both get something out of it, that's what you refer to as reciprocity. I give you something, you get something back. And I use this analogy in class a lot. I've got two saws here. This is what we refer to as a sawzall. And a sawzall is a type of a saw where the blade goes in and out. This is another type of saw. This is what we refer to as a jigsaw. So they work in the same way, essentially. So you got a blade here, and what it does is when I squeeze the trigger here, you can see that the blade goes in and out, in and out. All right, so the sawzall, we've got a number of different titles for this type of saw, and it goes real fast. So we've got a number of different titles for this type of saw. One is a sawzall, and I forget what one of them is, but this one works the same way. This is called a jigsaw, and it goes in and out as well. But specifically, the sawzall, what we refer to that as is a reciprocating saw. So it reciprocates, it gives and it takes. It goes in and out really, really fast so that you can saw something with it. So the law of reciprocity means give and take. And what that means is mass equals mass. And so I've got a number of different things here. 100 MA times 1 second gives us 100 mass. So 100 times 1, MA times time in seconds gives us our mass. That's milliamperage seconds. So now we've got tube current with 100 mass, 100 MA times 1. But if you do the math, 200 times half a second gets you at exactly the same rate. 100 mass, 400 at a quarter second gets you the same thing. You could go in the opposite direction with it and go with 50 MA at 2 seconds would also give you 100 mass. So as long as your machine is calibrated properly, then all of those 100 mass values should be identical. Nothing else matters. All of that just should be the same value. So let's say you make an exposure and your exposure is at 75 kVp at 100 mass using 100 MA at 1 second. So what you're gonna get is a relatively long exposure. Most of your exposures are in milliseconds. So you've got a relatively long exposure in 100 mass. And if you make an exposure on something, you might have an issue with motion with a patient. So what you might want to do is increase your MA and reduce the time, and that would reduce your likelihood of having a motion artifact. So if you use the same kVp with the same MA, or a different MA, doubled your MA and cut your time in half, then your index number should indicate the exact same exposure if your machine is calibrated right. If you start off with 100 MA and you increase to 400 MA and you reduce your exposure time to 1/4, you still have 100 mass if you use the same kVp. All three of these should give you the exact same image receptor exposure. So it can be used to reduce motion artifact. It's the motion artifact's the main thing that can destroy the sharpness of recorded detail on your image. And it's also the main thing that you can't control at all. You know, if your patient's going to move, your patient's going to move. If they don't intend to move, if they've got maybe Parkinson's disease or some other condition where they just can't be still, then you're going to have to adjust to that patient. And how you would adjust to that patient and minimize your likelihood of introducing a motion artifact is increase in MA and decrease time. Use the law of reciprocity. So if you increase one, you decrease the other, land on the same mass value, you should have the same exposure, and you should be able to change your likelihood of having a motion artifact. But you can also use the same thing if you want to use motion to blur something out. So going all the way back to the second slide after the intro slide, the things that we were going to cover, there was one down at the bottom is called TOMO. And tomography is the use of motion to blur out things that you don't want to blur out. So we used to use motion in the X-ray imaging system, like on IVPs whenever we're doing studies, contrast studies of kidneys. And what we would do is the X-ray tube would move in one direction while the image receptor would move in the exact opposite direction at the same speed. So they would remain lined up, and what would happen is whatever was at that pivot point would remain in relatively sharp focus, and everything else would blur out really bad. So that's what tomography is, but we can also use the patient moving their anatomy to try to blur something out. And that's what we refer to as auto, just like auto car, AUTO tomography. And we use those in things like breathing technique and the Ottinello method and the C-spine, where we move the patient's jaw, have them do a chewing motion so that it blurs out the jaw so we can see the upper portion of the C-spine. So mass just controls the number of electrons conducted through the anode. The only meter that we have that's in the high voltage section is the MA meter. It's wired into the dead square center of the secondary coil of the step-up transformer. It measures the actual number of electrons that comes through there. So mass is the number of electrons that are sent across the X-ray tube, conducted through the anode. It directly controls the number of photons that we create. It directly controls the quantity of radiation that we create because it's tube current and beam intensity. It controls the image receptor exposure directly, and it is consistent except for on falling load generators. We talked about falling load generators last semester, and this really should be more of a MA specific thing, not a mass thing. But with a falling load generator, what you get is I don't know if they still do or not, but they used to use these falling load generators on in equipment where we're doing rapid exposures of things that would not be still, like for example in cardiac catheterization. What they want is to make the exposure and make the exposure with as short an exposure time as possible. The problem is that because of space charge limitations and things that we talked about last semester in physics, is once you heat that filament up and you start sending those electrons across the tube, you can't replenish that space charge fast enough to keep a consistent flow of electrons. So what happens with a falling load generator is it starts at the highest possible MA, and it shoots until it runs out of electrons. It drops it a little bit, and it shoots until it runs out of electrons. It drops it a little bit more. So the load, in this case, what we're talking about is the amperage, drops throughout the exposure. And the purpose for that is to shorten the exposure time as much as possible. So MA is consistent throughout the exposure except for on falling load generators. So SID is source to image receptor distance. That is the distance between the target inside of the X-ray tube and the image receptor. So if you're working on portables and there's a tape measure that you can use to measure your SID, take a look at that tape measure. Chances are the tape measure starts at 12 inches. And the reason for that is because you're not measuring from the collimator housing to the image receptor. You're measuring from inside of the tube housing, inside of the protective housing, inside of the X-ray tube at the target. From the target, the source of all X-rays to the image receptor is SID. So it's independent of tube current, meaning that you can increase or decrease SID and the tube current doesn't change. And that comes with a caveat that if you're phototiming, the tube current will change. But unless you're phototiming, if you're setting a technique, then SID is going to be independent of tube current, meaning that what you do with SID has no effect on tube current at all. So you increase your SID, you make an exposure, you get a specific mass, and it exposes the image receptor. If you increase your SID, you still get the same mass, but the effect at the image receptor is going to be different. So it's independent of tube current, it's independent of tube emission, the emission from the X-ray tube, but it does determine the intensity at the image receptor, and we'll take a look at that here in just a second. So we've got two different laws that govern SID. One is the inverse square law, and one's a direct square law. So the inverse square law we covered last semester, and the inverse square law, and you're probably going through it in radiobiology if you haven't already, but the inverse square law tells you what changes in exposure you have with changes in distance. So that assumes that you have made no changes in mass, and we talked about this. We'll run through the examples again here in a minute, but it assumes you're not changing your mass, you're not phototiming. It is that if you increase distance, you decrease intensity at whatever absorber you're talking about. So it could be at the image receptor, it could be your scatter radiation that you're collecting inside of your body or inside of your apron whenever you're doing a fluoroscopy exam. So as distance increases, intensity decreases. Okay, so this is the inverse square law. Inverse means as one thing goes up, another thing goes down. So it's kind of like reciprocity. If you increase MA to maintain the same mass, you got to decrease time. Only it's a little bit different. In this case, with an increase in distance, your intensity is going to decrease. So what you have then is that if you were to be making an exposure and you made an exposure field that was maybe 4 inches by 4 inches at 40 inches, and you made that exposure and it was perfect exposure, and then you backed your X-ray tube up to 80 inches, then all of that exposure that was going into the 40 inches is going to be expanded out considerably. So you're going to have a tendency to say, okay, well, if I double my distance, then the coverage is going to double as well. And you're kind of right in that if you double your distance, you go from 40 to 80 inches, then that 4-inch square is going to spread out, but it's going to spread out in 2 dimensions. So it's going to double, but it's going to double in 2 dimensions. So instead of having, let's say I'm making exposure and I'm just wanting to make an exposure of my heart, all right? And some will say I don't have a heart that's any bigger than that. But if I just make an exposure this big, and that's all I'm interested in seeing, if I back up to 80 inches, then what's going to happen is that's going to change, and it's going to double in 2 different dimensions. So I'm going to have that much here, that much here, that much here, and that much here. So it's spread out over an area 4 times as large with the same exposure. So if I were to be taking a reading of how much exposure I had in my original area, it would decrease by a factor of 4 because it's changed the amount of exposure, that same amount of exposure has been spread out over an area 4 times as much. So it's inverse, meaning that as we increase our SID, our intensity decreases by a square of the distance. So I doubled my distance. I went from 40 inches to 80 inches. So I doubled my distance. I square that, and the decrease is going to be equivalent to the square of the change in distance. So if I had if 4 mass was perfect, the perfect exposure at 40 inches, at 80 inches, then what I'd have to do is quadruple that. Well, I'm sorry, I'm getting ahead of myself. It would, the area of exposure would decrease by a factor of 4. So it will be equivalent to 1 mass in that exposure. So increased distance, decrease intensity at the image receptor, but it's the square of the change in distance. So if you double your distance every single time, the exposure in that area would drop by a factor of 4. So how do you use this? In a practical sense, what you do is you increase your distance from the radiation source as much as you can. So most of the time we're talking about inverse square law, what we're talking about is not mass, it's not even mass equivalent, it's radiation exposure, and it's going to be read in something like MR, that's milliroentgens, millirems, or could be milligray. So how you use this in a clinical setting is you increase your distance as much as possible. So you're doing a fluoro exam and you're standing 1 foot away from the patient because you're giving the patient, barium or whatever you're giving them. And as soon as you get done giving them, you don't have to stand right next to the patient anymore. You can take a step backwards. So if your radiation exposure at 1 foot is 4 millirems per hour, then if you take a step back and you double from 1 foot to 2 feet, then your radiation intensity striking you, it's all going to be scatter radiation coming out of the patient, is going to drop by a factor of 4. So if you take 2 steps back, it's going to drop even further. So the further away you can stand from the radiation source, and your radiation source should be your patient, then the less radiation dose that you're going to receive. So if you have an apron and you step back, take a step back away from the patient, then your radiation dose drops dramatically. So on test questions, what you're going to be looking for to spot inverse square law questions is a number of things. One is look for the word dose. Your dose at 1 foot is so much. How much dose are you going to receive at 2 feet? Make sure you read the entire question. There aren't any complex questions on my personal test for this semester that will get into this, I don't think. But you'll see them eventually, and my students will see them in their sophomore image creation class. But what you may have are questions that say, okay, your dose per hour is 10 millirems at 1 foot. How much would your dose be at 2 feet for 5 minutes of exposure? So what you would have to do is you'd have to work the inverse square law. You double your distance, so it'd be 2.5, and then you'd have to calculate, based on the per hour dose, you'd have to divide by 12 to give you 5 minutes. So make sure you pay attention to that in your test questions. So what you're going to look for are, your radiation exposure. Radiation exposure at 1 foot is so much, or your dose at 1 foot is so much. And also look for the dose measurements of milliroentgens, milligray, things like that. So we've got a corresponding law that goes along with the inverse square law, and that is how much of a technique correction you need to compensate for increases in distance. So it's not just enough to know that as you increase distance, intensity is going to drop by square of the distance, but you also need to know how much of a change that you need in order to compensate for that. So your change is going to be in mass, and it's going to be worked almost exactly the same way. It's just going to be in reverse. So the inverse square law is going to be set up like this. Intensity 1 over intensity 2 is equal to, this really probably would be better set up as D2 squared over D1 squared. So notice that what we've got is in the numerator, we've got the original value in intensity and in distance. It's in the denominator. So it's inverse square law. So one flipped, right? So if the technologist dose at 1 meter is 1 MR per hour, what would the technologist dose be at 2 MR? So again, what we did was we doubled our distance. We went from 1 meter to 2 meters, and our intensity dropped by a factor of 4. So this is an inverse, meaning one goes up, the other goes down. Square, meaning that it's going to be the square of that change in distance. Law meaning that it's a property of physics that doesn't change. You can work it 1,000,000 times and it's always going to work out the same way. Every single time you double your distance, providing nothing else changed, then the intensity is going to drop by a factor of 4. All right, so it doesn't matter if you go from 1 meter to 2 meters. It doesn't matter if you go from 1 foot to 2 feet. It doesn't matter if you go from 1 inch to 2 inches. The amount of change is going to be dependent on the amount of change in distance. So it's inverse square law. You don't ever have to work it again. If you double your distance from 1 meter to 2 meters, then you know that your radiation dose is going to go down because it's inverse square law by a factor of 4. Increase distance, intensity goes down, square the distance. Double, always factor of 4. 2 times 2 is 4. All right, so direct square law is the one that tells us the change that we need to make in mass as we change our distance. So changes in technique required to maintain exposure when changing SID. So it's almost always going to be a change in mass. There could be a time where you would want to make a change to kVp, but I've not seen yet that change in the registry review books that there's any kind of consistent change in kVp to compensate for the increase in distance. So this is a direct square law. So walking back through it, this is direct. So one thing goes up, the other thing goes up. Square, again, it's going to be a square of the change in distance. In law, it's always going to happen the same way. So if the inverse square law causes us to our radiation exposure to decrease by a factor of 4, then if we were to change our SID, this is now to the image receptor, this is not scatter radiation, it's not your dose, then what we're going to need is a change in mass, and the change in mass is going to be proportional to the change in radiation intensity over here. So if we double our distance, let's say we made a perfect exposure at 40 inches today, and the patient had a miraculous recovery. We made the perfect exposure yesterday at 40 inches. Today we walked back into the patient's room. They had a miraculous recovery. We can do an upright chest x-ray on the patient. We can't get to 72 inches, but we're going to get to 80 inches. Then what we would need to do is increase our mass value by a factor of 4. It goes in the same direction, squared of double change. So you would increase your technique by a factor of 4. kVp is not what we're going to change. It's going to be mass. So double the distance, quadruple the mass. Always, you don't ever have to work it again if you double your distance. So how to spot direct square law questions? You're going to look for mass in the question. Your original mass was what? So that should clue you in that we're working direct square law questions, and your mass needs to change appropriate to the change in distance. So if you increase your distance, excuse me, if you increase your distance, then your radiation exposure, your mass rather, is going to need to increase. If you decrease your distance, you're going to need to decrease your mass. So look for mass in the question. Your original mass was, what new mass would be needed if you changed your SID from one value to another? Or look for image receptor exposure. What would you need to do to maintain image receptor exposure with an increase in SID? It's direct square law. One goes up, the other goes up. So you increase your SID, you need to increase your technique. If you double your distance, you double your SID, then you need to increase your mass by a factor of 2. So also look for what would happen to image receptor exposure if you increased your SID and made no other changes. So it might ask you something like this to indicate that you underexposed the patient. So if you made perfect exposure, you increase your image receptor, your SID, then your image receptor exposure would decrease by a factor of 4 because of the inverse square law. And what that means is you just underexposed and you may have to make another exposure. So the direct square law is set up much like the inverse square law, but it's going to be mass 1 over mass 2 is equal to D1 over D2 squared. So always double the distance, always 4 times mass. So in both the square laws, most common mistakes that you're going to make on the test are using the wrong square law. So sometimes you might apply the inverse square law to a direct square law question. So make sure that you pay attention to the question and what it's asking you. Again, radiation exposure, MR, dose, things like that are going to be indication that you're using the inverse square law. And mass and image receptor exposure are going to be your direct square law. Technique correction, always the direct square law. So the other thing is forgetting to square the distances. So what you're going to see are, in a lot of cases, are answers on the test that will catch you on one of these two. So let's say I give you a test question and it asks you something like this. You made an exposure upright portable chest x-ray with 80 kVp, 2 mass, 40 inches. If a repeat exam was needed at 80 inches, what new mass would be needed? I might give you an answer on the test that says, let's see, you had 2 mass, so I might give you an answer that says half mass, 1/2 of a mass. Okay, so what that would be is the right answer to you applying the inverse square law to this question. I might also give you another answer that says 4 mass, which would be the right answer if you didn't have to square your direct square law. Okay, so both of those may be an answer on the test that will trip you up if you're not paying any attention. So make sure that you don't make those 2 mistakes. Use the proper law and don't forget to square your distances. Double the distance, there's always a change by factor of 4, always. But we don't go from 40 to 80 inches, we go from 40 to 72 or 72 to 40. Okay, well, again, it's still a law, okay? And so I'm only gonna work one of these because they work exactly the same. It's just in the reverse order, so I'm gonna work the direct square law as it applies to changes from 40 to 72 inches. That's what this was. So if a chest x-ray was made on a patient using 80 kVp at 40 inches yesterday and needed to be repeated at 72, what new mass would be required to maintain image receptor exposure? And you don't have enough information there. So that would be a bad question on test. So let's change that real quick with 1 mass at 40 inches. So there, and get back to it. So we got 1 mass today. So 1 mass would be 1 over x. We know what our old mass is. Our mass 1 is. We don't know what our new mass is. So it's 40 squared over 72 squared. So what that would equate to is 1 over x is equal to 1600 over 5184. Cross multiply and then divide out, and you would wind up with 3.24. So from 40 to 72 inches, you would always increase. Again, this is a direct square law. If you increase your distance, you're always going to increase your mass by a factor of 3.24, providing you're going from 40 to 72 inches. If you're going from 72 inches to 40 inches, you would divide by 3.24. Applying that to the inverse square law, if you increase from 40 to 72 inches, you would divide by 3.24 to get your new radiation exposure. or if you went from 72 to 40 inches, you would multiply by 3.24. Laws, always the same. So now you don't have to ever work this again. If you go from 40 to 72 inches, it's always going to be a factor of 3.24. If you go from 72 to 40, it's going to be a factor of 3.24. Just don't forget to go in the proper direction. So if you increase your SID, your technique always has to go up. If you're increasing from 40 to 72 inches, your technique always has to go up by a factor of 3.24. If you're going from 72 to 40, your technique has to go down by a factor of 3.24 every single time. So focal spot, what the focal spot is the area on the target where the X-rays travel across the tube from the cathode to the anode, and they slam into the cathode, into the anode. It's that place where they hit. That's a focal spot. So you've got really two different focal spots we have to consider. One is the actual focal spot, and that's what I'm talking about here. It's the actual focal spot. But you also have what we refer to as the effective focal spot. The effective focal spot is if the patient could look up into the X-ray tube and see the target, the face of the target, what they could see would be an area that would be significantly smaller. So like if this was the target and I showed you the target in the actual area of bombardment, it looked like it was this big. But if I turned it so that you were looking up at it, then it would look significantly smaller. Okay, so effective focal spot is line of sight from the patient, as opposed to actual focal spot is where those electrons impact. So in our X-ray tubes, you generally have two. So what controls that is your filament size. So your filament size is going to be represented on your control panel by boxes in boxes, let's say. So you got a button on your control panel, and one has a great big box on it, and the other one has a smaller box on it. So the small box indicates small focal spot size. The big box indicates the large focal spot size. So what that is doing is it's selecting a different size filament. Most of your X-ray tubes have what we refer to as dual focus, meaning we have two filaments, but we only have one area of impact on the anode. So it's dual focus tube because we have two filaments, and those filament sizes in most of your diagnostic tubes are represented here. So it's a half a millimeter and a 1 millimeter, or it could be a 0.6 and a 1.2 or a 1 and 2 millimeter. So what you're going to find as you go through the curriculum is that all of your controls and your settings are going to have a specific variance. And what that is how inaccurate something can be and still be accurate enough to be called accurate. Like your collimation. At 40 inches, your collimation can be off by, I say 3/4 of an inch. It's really 0.8 inches. Is 2% of the SID. So if we're at 40 inches, 2% of that would be 0.8 inches. So that's how far off your collimators can be and still be considered accurate. So the same thing applies to focal spot size, and we'll talk about those here in just a second. We do have special X-ray tubes where we need a higher resolution than what a diagnostic tube gives us. So going back to this is really a pretty sharp focus X-ray tube for a diagnostic tube. Most of your X-ray tubes are going to be somewhere around in one of these two. So special procedures, because in special procedures in cardiac catheterization, we're looking for blood vessels with contrast in them, and some of them are very small. We need smaller focal spot sizes. What the smaller focal spot size gives us is a sharper image. So it brings up spatial resolution, it makes a sharper image. So we need that in special procedures. So part of the reason for that is traditionally what we've used also is what we refer to as magnification radiography. In magnification radiography, what we used to have to do to get to magnification radiography is to increase our OID. So we have two distances that we utilize for the most part, really three, but two primarily. One is SID, and that's the one we use and talk about the most. The other is OID. OID is the distance between the image receptor and the object itself. So how we used to get magnification in special procedures was by increasing the OID. It was an intentional increase in OID to give us magnification. So most of the time we want our OID to be as low as possible, decrease magnification, because with magnification what we get is a loss of spatial resolution. So if we have an increase in OID, then we need something to reintroduce some of that sharpness of recorded detail. And that's why we use what we refer to as fractional focal spots in special procedures. So special procedures uses an X-ray tube with even smaller focal spot size. And then mammo, what we're looking for are microcalcification in breast tissues. Just backing up just real briefly, the second thing that I told you we weren't going to talk a whole lot about was macro radiography, and that's what that is. Intentional magnification, intentional increase in OID to use magnification as intentional magnification radiography. So you may have test questions that ask you if what you're trying to accomplish is magnification radiography and you increase your OID, what do you do to increase your sharpness of recorded detail? So what you're going to be thinking, your first response is increase in OID. I need to increase my SID to overcome that magnification loss of sharpness of recorded detail. Problem with that is if you double your OID and then you double your SID, then your magnification doesn't change. Your sharpness of recorded detail doesn't change really either, but what you're trying to introduce here is magnification. So if you increase your OID with the purpose of increasing magnification, then the only way to reintroduce that sharpness of recorded detail is to use a fractional focal spot, a smaller focal spot size. You don't want to increase SID in magnification radiography. So in mammo, what we're looking for are tiny pieces of calcium inside of breast tissue. So in order to visualize those, what we need is a very, very small focal spot. So that's what we're going to refer to as microfocus X-ray tube. So I mentioned this before, acceptable tolerances in our focal spot sizes. If we have a large focal spot, then the accepted variance is 30%. And the smaller the focal spot gets, the more acceptable it becomes to be out of whack, so to speak, I guess. So the larger focal spot, the tighter the variance. The smaller the focal spot, the more loose the variance. It seems like it'd be the other way around, but it just is tough to maintain the stream of electrons into a tight formation to strike in just the perfect place on the anode, the smaller the focal spots get. So that's why you have more leniency with a smaller focal spot size. So how we use that then is with small filament, we're going to use small filament for small anatomy. So thin anatomy, if we're interested in detailed trabecular markings, we're going through skulls in positioning this semester. So to really see the detail in the ethmoid bone, you're going to need a small focal spot. In extremity work, you're going to need a small focal spot. But you don't want to use a small focal spot whenever you're using big exposures on things like the abdomen. So thin anatomy, where you need detail, you're going to use small focal spot, as opposed to where you're going to create a lot of heat, you're going to use the large focal spot. So large anatomy, large filament, large heat loads. You don't want to burn out your small focal spot, which you can using high mass exposures on small focal spot can absolutely burn it out. Doesn't necessarily mean that your X-ray tube isn't going to work anymore. You still have large filament. You don't have two filaments as a backup. You have two filaments, one for detail and one for large heat loads. But if you burn one out, then that doesn't necessarily mean that the X-ray tube itself is instantly non-usable. It needs to be replaced, but you can still make exposures on the other filament. So large filament, you're going to use the large filament whenever you're imaging large anatomies with high heat loads, higher MA stations, because you just can't get below 200 MA or above 200 MA on a small focal spot. And anytime that you can use that higher MA to get a shorter exposure time, we'll use a large focal spot. So the effects on image receptor exposure, here's a frequent misconception, and that is that if you use a small focal spot, then your image receptor exposure is naturally going to go down, and it's not. So if your machine will allow you to make a 100 mass exposure on large and small focal spot, as long as your machine is shooting properly, mass is mass. So it doesn't matter if it's on a large focal spot or small focal spot, it's just count of electrons. Count of electrons, count of photons. So your mass exposure should be identical. So your image receptor exposure between large and small focal spots should be the same. That does come with one sort of a caveat, and that is that if you try to make too high of an exposure on a small focal spot, you're going to get a tube overload light, and it's not going to let you make that exposure. But that's not what this is asking. The effects on actual image receptor exposure, as long as your machine will allow the exposure, then focal spot's not going to have any impact on your exposure. It's not going to have any impact on penetration, that is your kVp. And aside from the things that I talked about before, it's not going to have any impact on mass, and mass is not going to have any impact on it. So filtration, we've got three things to consider in filtration. Really two categories of filtration. Got my coloration mixed up here. We're going to have two different types of filtration, and one of those is going to have a subcategory. All right, so we've got inherent filtration, we have added filtration, and a type of added filtration is compensating. So inherent filtration is anything that you cannot remove from the imaging system and still make an X-ray. Okay, so for our purposes, we're going to consider everything up to where we can legally make an X-ray to be inherent filtration. So that would include the glass or metal envelope, it include the oil inside of the housing, it include the port where the X-rays come through the housing, it include the back side of the mirror, and anything that we had to add to that chain of things to penetrate to get to an equivalent of 2.5 millimeters of aluminum. So that's all inherent filtration. Added filtration is anything that comes above that. So if for whatever reason you were making an exposure, let's say you were working at a pediatric hospital and the hospital protocol was to have 3.5 millimeters of aluminum, then I guess it'd be splitting some hairs there. That would be their inherent, but really from a standpoint of an industry standard, that extra millimeter of aluminum would be added filtration. So in addition to added filtration, what we've got is compensating filters. So where we see compensating filters mainly now is in, and it's really not so much a overall filtration as much as it is a breast dose reduction measure. So you don't see a whole lot of compensating filters in a diagnostic setting anymore, but if you do a significant number of scoliosis series, your patient population of scoliosis series is usually going to be young females with developing breast tissue. So what we're going to have then is these compensating filters that you collimate down and you add the compensating filters as an extra absorber so that the especially low energy X-ray photons don't make it to the breast tissue. So that's a compensating filter. We used to use compensating filters on things like feet and T-spines, any kind of anatomy where we had a distinct difference in thickness between one end and the other. So feet are kind of wedge shaped, so what we would do is put the thick end of the wedge over the toes and the thin end of the wedge over the proximal portion of the foot to compensate for tissue density differences. So that's a compensating filter. One thing that I did fail to mention in inherent filtration is that an added type of inherent filtration is what we refer to as tanning. So you make your exposures over and over and over again, and you heat the filament up, the filament vaporizes, and it coats inside of the X-ray tube. that is still an inherent filtration. It's just an increased inherent filtration. And we consider it an inherent filtration because you just can't get rid of it. You can't take it out. So you can't separate that from the X-ray tube, and it just becomes a portion of the system as inherent filtration. So the effects of filtration on image quality, the effects on kVp, as far as the peak energy goes, it doesn't have an effect. But the average energy, it does. So by eliminating low energy X-ray photons, it pushes the BRIM spectrum towards a high energy side and increases the average. I like to use the example in class that if you were to have 10 test grades, and let's say your average was 80, and we threw out the lowest test grade so that now you have 9, but you got rid of the lowest one, your average would increase. So it's kind of the same thing by eliminating low energy X-ray photons. What we do is we get a higher average. So it doesn't really have any effect on contrast. On contrast, it doesn't do anything to contrast really, because your computer algorithm is what controls your contrast, but it does affect beam quantity, and that is it does affect image receptor exposure. So anytime we add filtration, but especially the compensating filters, we're going to have to increase something, and that something is going to be mass. So the purpose for filtration, the original purpose for filtration, if you think all the way back to the first chapter, second chapter of Bushong's, Rollins introduced filtration to reduce patient exposure, to reduce those low energy X-ray photons that aren't going to do anything but absorb inside of the patient. So filtration decreases patient dose. When I talk about generation, I'm talking about the voltage waveform. And what we get as we change generator types is we go from single phase to three phase to high frequency, or even three phase to three phase 6 pulse to 12 pulse. Then what we get is more consistent voltage throughout the exposure. On single phase, our voltage waveform drops to 0 to no output. That will be, if it's unrectified, it would be 60 times per second. If it's rectified, it will be 120 times per second. Once we get to three phase, it never drops all the way down to 0. So again, it increases the average. Once we go from three phase to 6 pulse to 12 pulse, then it again increases that average, so that ripple decreases. So if you remember from last semester, we talked about the voltage ripple for single phase was always 100%. It goes from start to stop, to start to stop, to start to stop, 60 or 120 times per second, depending on whether it's rectified or not. And then once we get to three phase 6 pulse, that voltage ripple drops from 100% down to about 14%. And then three phase 12 pulse is down to about 3%. High frequency is less than 1%. Constant output would be a 0%. So what that does to the BRIM spectrum is it increases the output from single phase to three phase. It increases output, so the height of the bubble goes up, and then it pushes it towards a high energy side. It doesn't change the minimum or the maximum. It has no effect on the characteristic spectrum. It just increases the numbers, and it pushes towards a high energy side. So you might have a tendency to think, okay, from single phase to three phase, then our technical factor change is going to be a factor of 3, and it's not. It's going to be a factor of 2. From single phase to high frequency, it's going to be about 2.5. So it's a little bit different, a little bit higher than three phase, but it's not going to be the 1 to 3 that you might think. So how do we use that, and how do you pick the answer out of a test question? As we go from single phase to three phase, we get an increase in output, so we need less mass to make the exposure. So let's say we're doing a kUb on a patient in a single phase room, and we need 32 mass. You pick the kVp, we need 32 mass on a single phase room in a single phase room. Then if we change, let's say that we need to repeat, is a good technique, but we need to repeat in a three-phase room, then what we're going to do is we're going to move the patient to the three-phase room. We're going to divide our mass by 2, and now we need 15 mass. So if we go from single-phase to three-phase, then we divide by 2. If we go from three-phase to single-phase, we multiply by 2. So that's what you would do, is you would change your mass from single-phase to three-phase or high frequency. You got to decrease your mass from either one of those to single-phase, high frequency to single-phase. You're going to have to increase your mass. So the effect on the beam in the image is, if you don't make those changes, then what you're going to wind up with is a beam with, if you're going from single phase to three phase, inadequate number of photons, and therefore your image is going to, your index number is going to indicate that you underexpose the patient. So again, your voltage ripple, 100%, 100%, three-phase 6-pulse would be 14%, 4%, I think I said 3% a minute ago. Three-phase 12-pulse, then high frequency would be less than 1%. So two things that I need to add to this that didn't make it into the slide is that automatic exposure control is a means of the machine and the computer automatically setting your mass whenever you make an exposure. So I've described this in class, but just to refresh, what you have are an array of radiation detectors inside of your bucky, be it in the table or in the wall. So you may have 3, you may have 5. So the arrangement, typically if it's 3, it's going to be 1 dead square in the middle, and then you've got 2 that would indicate exposure through the middle of the lungs. So if you're doing a chest x-ray, what you might want to do is use those 2 outer cells. If you're shooting an upright abdomen or maybe an upright T-spine or something like that, you'd use center cell. Some of your other arrangements may have 5, so they may have 2 on top, 1 in the middle, and 2 on bottom. So what those do is they're just counters for radiation exposure. So what you get with those is if you're making an exposure, it just counts the number of X-ray photons, and it sends a signal over to the timer circuit to discontinue the exposure whenever it gets to the right amount. So like 5. So let's say that it counts up to 5 MR before it sends a signal over to the timer circuit to kill the exposure. So you make an exposure, and you put the patients now, you properly position. Let's say we're doing a chest x-ray, so you use those outer cells, and you're doing an upright chest x-ray, and you make your exposure, and once those radiation detectors get to the right amount of exposure, it sends a signal that says terminate the exposure. If you have a patient with pathology, let's say we've got a patient who has a massive pleural effusion, fluid in the lungs, and it's completely obliterating one lung, and they've got total atelectasis on that side. You can't see the lung at all because it's full of fluid. Then what's going to happen is that radiation detector on that side is going to have to stay on longer to get to those 5 MR to send that signal over to the timer circuit to kill the exposure. So it automatically sets your mass, and if a patient has a pathology, it compensates for that. And as I mentioned, I think in the last video on kVp, if you increase your kVp, the only thing that's going to happen is that your mass is naturally going to decrease, because you increase penetration through the patient, increase that penetration through the patient, and it gets to that 5 MR quicker. So it just shortens the exposure time. It doesn't really affect your exposure at your image receptor. It can affect patient exposure, but not to the image receptor. So that's just automatic exposure controls in, 2 minutes or so. We're going to talk about different types of technique charts in the next section, and one of those is what we refer to as APR, and that is automatically programmed radiography. And it's not really a technique chart as much as it is what you're probably most used to is you go to your control panel, and instead of selecting your cells, instead of selecting the outer cells for chest x-ray, you push a button that says chest x-ray on, and you may have a selection of 2 or 3 different types of patients. So large patient, you push the button, and what it's going to give you is going to give you a kVp It's going to select your cells for you, and it's going to set your MA, and you make your exposure, and it should be a good exposure, providing you position properly. The problem with automatic exposure controls is you have to position properly. If you position improperly, if you position off somewhere, you select the wrong cells, then what you might wind up with is over or under exposure. So you have to position properly. For example, if you're doing a clavicle on a patient, and this is a mouse, and we'll try to keep from messing anything up, but if you've got direct exposure, let's say this is your photocell, and it's sticking up above the patient's shoulder, and you make an exposure, that thing's going to get direct exposure, and it's going to terminate the exposure very quickly. So positioning has to be really accurate. You have to completely cover up the photocell in order for it to work properly. So there's that. And the other thing is magnification. So what you see on page 230 of Bushong is magnification factor, and how much of a magnification you're going to have. So I kind of touched on this a little bit when I was talking about magnification radiography. Intentional increase in OID to get us some magnification, and that's what this is referring to. But you can calculate the actual magnification factor of anything, providing you know image size, object size, SID, SOD. If you know three of those things, you can calculate exactly how much magnification you have. So if you have an object that is 2 centimeters above the image receptor, you're going to have magnification. And if you go to 4 centimeters above, you're going to have increased magnification. So magnification factor is calculated as SID over SOD is equal to image size over object size. So SOD, what SOD is source to object distance. That's that third distance I was talking about. So how you calculate SOD is to subtract your OID, your object image distance, from your source to image receptor distance. So that gives you your SOD. And so a couple of different ways you can work magnification factor. One is the way I mentioned before. The other is image size over object size is equal to SID over SOD. So that's just the reverse of it. So here's the thing about formulas like what we're seeing there. That's what we refer to as a ratio type formula. Inverse square law, direct square law are the same way. And that is these two things, one over the other, is equal to these two things, one over the other. And since you're going to be cross multiplying those two quantities, it doesn't really matter which way you go with them, right? So if you set them up improperly, as long as you set them up properly, improperly, then it doesn't really matter. You can actually flip the whole thing over and come up with the exact same answer, but if you flip one over, then you got a problem. And if you take the inverse square law and you flip the whole, inverse square law, let's do it like this. So you got this thing, is the opposite of this thing, right? So if you flip both of them over, it doesn't really matter, right? But if you flip one over, now you got the direct square law. So magnification factor, just how much magnification is present. Spoiler alert, you always have magnification present. Even if you're doing a hand x-ray because of the soft tissue on the hand, you're going to have magnification present. It's very minimal, but you do have magnification present. So those were the only two things that didn't make it in the PowerPoint. So the next video will be chapter 16, and that will be patient factors. So if this was helpful, please like, subscribe, share, and I'll see you on the next one.